Thank you, ma'am. So very good afternoon to all. So as ma'am said, today we are going to learn about gastrointestinal symptoms, which is on nausea, vomiting, and constipation, which will be taken by Dr. Arjun, who is a palliative care physician and having more than 3 years of experience in palliative care. And he is right now he is heading the medical service department. Dr. Arjun, welcome and over to you.
Thank you, Sister Shiva. So, good evening all. So we will today have a session on management of gastrointestinal symptoms. So we will start with nausea and vomiting. So we will start. It would be good everyone if everyone could switch on the videos.
So please put on your video. Samir Pradipa. Hey Mary. Mamung Lego. Please. Pradipa, are you there? Okay, very good.
Thank you all. So we'll start with what's nausea. Nausea is an unpleasant feeling of need to vomit. So what we see is it's usually accompanied by some autonomic symptoms like pallor, the cold sweats, salivation, tachycardia, and in some cases even diarrhea also. While vomiting is a forceful expulsion of gastric contents through the mouth. So the question is, how does these symptoms, the nausea and vomiting, have effects on patients? So how do you see what are the effects of severe nausea and vomiting you have seen on your patients? So who will be answering this? What effects does nausea and vomiting have on patients? Mr. Sunny, could you please answer that?
Well, any patient keep having nausea. Am I audible?
Yes, sir.
Okay. Patient will having a nauseatic effect. So, abdominal cramps will be there.
Okay.
And some kind of abdominal pain will be there.
Okay. So I was more thinking out what effects these symptoms have on patients. Okay. Mr. Samir?
Yes, sir.
Mr. Samir, could you answer more? Could you add more points to what Sunny said? Mr. Samir, you are muted.
Yes, sir.
So what are the effects do you think the nausea and vomiting has on patients?
Sir,
Yes, sir.
hello.
Mr. Sunny, you are audible.
Okay. Yes, sir. As I already told you that because of nausea, patient will have some kind of, because of the use of muscles, abdominal muscles. So patient will feel, pain and
Yes.
abdominal pain. Also, due to nausea, Um, I think that's it, sir.
Okay, thank you, Mr. Sunny. Does anyone want to add anything more? Madam Pratibha?
Patient will feel dry mouth and all due to nausea.
Yes, sir.
Okay. So anybody wants to add anything more? So otherwise you can put the answers in the chat box too.
Madam, do you want to add something? Madam Sarah?
Nirosha?
Okay. Mr. Sunny has answered rapid heart rate, yes. Okay, we'll move on. So, yes, of course, inability to eat adequately. Yes, that's a very big effect that's going to happen on the patients. So one of the other things that we could see is poor control of other symptoms. So the patient who has severe nausea, vomiting, they won't be able to take medications. The other conditions which are already under control with the help of medications could precipitate. And then there is a decreased food intake. So dehydration, electrolyte imbalances, adverse drug reactions. Okay.
Hello.
Yes. Even Mr. Sunny, you want to ask something?
Something sound is coming from somewhere, irritating sound. Some monitor kind of sound is coming from somewhere.
Okay.
Now it is closed. Now it is closed. Maybe from somewhere the monitor kind of sound. Now it is clear. Now
Okay. So most common causes of nausea and vomiting. Those are the peptic ulcers, gastritis, renal failure, ketosis, debility like constipation, cough, infection, even iatrogenic, those treatments which can lead to nausea and vomiting. Most commonly it is seen in the patients who are undergoing chemotherapy and radiotherapy. Then in cancer, the most common causes of nausea and vomiting are presence of blood in stomach, constipation, a bowel obstruction, hepatomegaly, ascites, raised intracranial pressure, which is commonly seen in brain pathologies when a patient will be usually presenting with severe nausea and vomiting with altered sensorium. That's how you will recognize a raised intracranial pressure. When there is cough, of course, the pain can severely cause this vomiting. There is anxiety, renal failure, hypercalcemia, hyponatremia. These are the most common causes we do see in a cancer patient for nausea vomiting. And the most common drugs which causes nausea or vomiting are antibiotics, corticosteroids, iron. Iron, which is very commonly seen that most of patients that we are going to see will be having an anemia and they will be put on iron tablets for correcting the anemia. Of course, they will be presenting with the nausea vomiting. Then there is NSAIDs and opioids. So how do we manage them? Initially, we could start with non-pharmacological cost management factors, like encouraging them to take small snacks at frequent intervals rather than big meals. Like if they are taking only 3 meals a day in the morning, a breakfast, lunch, and dinner, we could encourage them to take small snacks. The meal could be broken up into small foods. Like 9 o'clock, if he takes a normal breakfast, we could encourage them to take a small amount of food at 9 o'clock. And after 2 hours, like 10 or 11, we could ask them to take another snack. Then at 1 o'clock, rather than having the whole lunch, we could take a part of the lunch. After at 3 o'clock, then the rest of the lunch could be taken. So we could break up the meals into smaller snacks so that they could tolerate well. Then the sight and smell of food. The smell of food is something that is very commonly nauseating to these patients. Okay, so try to avoid them. So we have already seen those drugs which may be causing this nausea only. We could either minimize or discontinue or change them to new other drugs. Then distract from the thought of being nauseated. Relaxation techniques can be taught to them. Of course, then if pain is the most common thing, if pain is the thing that is causing this thing, we will have to address that pain and also address the accompanying social, psychological, and spiritual matters. Music therapy is said to be helping them to control the nausea. So then, so here in this picture, you can see that there are multiple centers in our body which help in the which has role in the vomiting. So let's start with the vestibular system, which is located in the inner ear. So they have two receptors, the H1 and ACH. So when these receptors get activated, they could lead to vomiting. So the most common things that causes vomiting by acting on the vestibular system are motion. So I think most of you will be available of the motion sickness, then the opioid drugs and base of skull tumors. And cyclosine is a drug which you could use to control the symptoms, where the vomiting is caused by activation of the vestibular system. The most important part is the chemoreceptor triggers on, or the CTC, which has the D2, 5-HT3, and NK1 receptors. These receptors are mostly activated by drugs, metabolic syndromes, and toxins. The most common drug we use to treat conditions that are causing vomiting by activation on this side is haloperidol. We also do use metoclopramide. Then there is a cerebral cortex where the GABA and the H1 receptors are there, which is usually activated by pain, fear, anxiety, and raised ICP. Drug of choice is there is also cyclosine. Then there is the gastrointestinal tract, which has the 5-HT4 receptors, the D2 receptors. The most common cause is gastric stasis. We could use domperidone or metoclopramide. Both are prokinetic drugs, which will help them. Then there is a vomiting center where H1, ACH, and 5-HT and K1 mu receptors are there, where the raised ICP will be causing the pain, and also meningeal irritation, infiltrations. Cyclosine, levomeprobamcin, and even dexamethasone will be helpful for treating conditions. Sorry. So here, a little more detail. When a metabolic or biochemical upset or changes in which are caused usually by drugs, the carcinomatous changes, chronic inflammation, metabolic changes, even electrolyte imbalances, they will be causing persistent severe or severe vomiting. There will be little relief from the vomiting. The patient won't say much relief after the vomiting. The distress will be persisting. So here we could manage the drugs which were helpful are haloperidol and metoclopramide. Likewise, motility disorders. The patient will be presenting with intermittent large volume vomiting. The patient will have much relief with from the symptoms after the vomiting, but it will be temporary. The patient will complain of early satiety. There will be hiccups, refluxes, and even one more thing to notice is that there will be little vomit nausea until like just immediate to the vomit test. Here, hypercalcemia is a very common cause of this condition. Then there is mechanical obstruction, the bowel obstruction, which is a very serious medical emergency commonly seen in palliative care, which the bowel tract will be obstructed. Bowel tract will be obstructed by a tumor or nodes or large liver. The drugs we could commonly use is metoclopramide or domperidone, which are prokinetics. And in cases of severe obstruction, compression, dexamethasone will be the drug useful here. And also mind erythromycin, which is an antibiotic, which is a prokinetic, could also be used here in certain conditions. Next one thing you see is intracranial disorders that usually seen are the raised intracranial pressure or vestibular stimulation, which the patient commonly presents a severe headache, altered level of consciousness, vertigo, delirium, and moment-related sickness. Here, usually are caused by the intracranial space-occupying lesions like glioma. Okay, hyoscine could be used for that. Dexamethasone is very commonly used in inner ear conditions. Cinnarizine would be the drug of choice. Then there is a gastric and esophageal irritation, where the patient will be present with constant nausea, which will get worsen on eating, and there will be gastric colic. Mind it, there is colic, we cannot use a prokinetic like metoclopramide. So these are commonly caused by the stimulation of the vagal nerve, and the drugs we could use are hyoscine. One more thing is most common patients will be immunocompromised, and our candidiasis in the GI tract will be very common in them, especially there will be infiltration to the esophagus, and they will be presenting with these issues. So an antifungal, if needed, could be added to this patient if it benefits. And even virus infections like herpes simplex, where an antiviral could be needed in along with. And to cover the gastric irritation, an antacid like ranitidine or a proton pump inhibitor should also be added. Prokinetics may trigger the esophageal spasm, so those conditions, those drugs like metoclopramide should be avoided in this condition. Then there is a multifactor refractory, including higher centers, which are not controlled by normal medications. Here, what we could try is dexamethasone. Steroid, what we do is usually start with an 8 milligram, and after 3 days, we could reduce the dose. Our aim should be to maintain the lowest possible dose, which is tolerable by the patient. Like if the patient is able to stay symptom-free for 2 milligram per day, we could maintain at it. But if the patient needs 4 milligram, we should have to maintain at 4 milligram. Levomeprazole and is another drug which is useful in this situation. And anxiety, one more, the pain, the fear, the anxiety, those are things which could also precipitate this refractory or multifactory vomiting. In such conditions, we need an anxiolytic. Benzodiazepines are the drug of choice there. Lorazepam or diazepam could be helping them there rather than any other antiemetics that we commonly use. A few adverse effects of the drugs we use, 5-HT3 blockers like the ondansetron or granisetron, they would be usually may lead to headache and constipation. Please mind this, most of our patients will be coming with the constipation. So adding an ondansetron to them will definitely add more to their constipation. So we have to think twice before adding that. keep an eye out. Then they also may cause fatigue or dry mouth. The dopamine receptor antagonist may cause extrapyramidal symptoms like akathisia. Then the most adverse effects that could happen are anticholinergics and antihistamines will be confusion, sedation, dry mouth, blurred vision, urinary retention. So for when prescribing to people above 50 years, male above 50 years, we will have to think, we will have to get a history of a urinary retention. If there is urinary retention, opt for another drug. Some practical considerations. When we are managing with a patient with severe vomiting, we have to pay our attention to hydration and the nutrition status of the patient. The nausea the patient could be already on an antiemetic, but he still may be having vomiting. But there could be lack of the efficiency of the antiemetic, because the patient could having, like what we said here. So the patient would be having the active vomiting could be due to action on the trigger zone. To have such a patient, if you are prescribing cyclosine, the patient won't be having a symptom relief. We have to prescribe a haloperidol or metoclopramide. That is why the importance of these mechanisms are that you should be aware before having the patient or putting a patient on a medication. Okay, it could be refractory. Benzodiazepines could be tried. So, anticipatory vomiting is a term that we use. The patient could be what we commonly see is the patient could start vomiting before the day before the chemotherapy. The patient which won't be responding to any antiemetics. There won't be any other triggers that we could diagnose for the patient. It could be usually by an anxiety which could be causing this vomiting. So benzodiazepine would be much more helpful for the patient at that point. And prokinetics, esophageal spasm can be triggered. So a patient with a colicky pain, we will have to should not be prescribed with a prokinetic. In complete bowel obstructions, there will be an spasmodic pain. So prokinetics should be avoided in such conditions, where it may even lead to a bowel rupture. Relaxation can help the patient as anxiety can worsen vomiting. So we have to keep the patient relaxed. Then whatever happens, the pain medication should be continued, as if the patient starts vomiting and the patient who's on an oral analgesic has to be stopped because of the vomiting. The pain will definitely, of course, it will go high and it will worsen the condition. So we will have to think of an alternate route. We could give the medication rather than only through a subcutaneous or IV route, or even a parenteral route could be used. Once the symptoms are controlled, we could change back to an oral form. Then small portions of food could be given more frequently, and plenty of fresh air. That's something that's going to help them relax. So next symptom is constipation. So who can tell me what's constipation? Okay. Shruti, Madam Shruti, could you answer? What do you think is constipation?
Shruti, are you there? Pratibha, are you there? Please answer this question. What is constipation?
Do not expect a by the book explanation. Just give me what you think is constipation.
Anybody want to answer the questions?
Absence of bowel movements. Okay. Does anyone else want to add? Inability to pass the stool. Okay, unable to pass the stools. Yes. Anything else to be added for this? Passing hard stools 2 to 3 times in a week. Okay. Difficult bowel movements. I would rather say in unsatisfactory and not irregular bowel movements to be constipated. So the stool may become hard, dry, and difficult to pass. Bowel movements don't happen very often. It will be very irregular or unsatisfactory. All these could add on to the term constipation. So even if the patient has opens bowel movements, okay, it happens. Okay, 3-4 days. Okay, it will still be an irregularly. Yes, it is. It could be satisfaction. Sorry, constipation, and satisfaction has another role. If the patient passes through, have a difficulty in passing stools, uh, he feels that he hasn't emptied enough, and it's unsatisfactory for him. It is constipation. So constipation could lead to anorexia, nausea, vomiting, bowel obstruction. There could be severe abdominal discomfort, pain. This constipation, in constipated patient, the stool which gets stored in the rectum could obstruct our urinary tract and even cause urinary dysfunction. So like there could be urinary retention, even hesitance. Then delirium. Okay, constipation is a very commonly thing which has precipitated delirium. So whenever patient comes to delirium, constipation has to be ruled out as it's a correctable cause of delirium. So now who can tell me what's spurious or secondary diarrhea?
Please answer these questions. Anybody heard about spurious diarrhea or secondary diarrhea or overflow diarrhea? Anybody?
Yes. I'm sorry if you have heard of it. Have anyone heard of it?
Yes or no? Nurses, please answer the question.
Along with Mr. Sunny Bama has answered, along with small bowel, both absorption, secretion of fluid and electrolytes occur. I'm sorry, I didn't get what you meant. So Samir, Nirmi, Ain Mary, anybody? Nirosha, Rahani Gaurkar. Since spurious diarrhea, a patient who comes with a secondary diarrhea or an overflow diarrhea, so they will be coming with complaints of diarrhea, passing of watery stools, which is very foul smelling, and usually it will be preceded by a period of constipation. So what happens here? Okay. So what happens here is that during the patient is primarily suffering from a constipation, where the constipated stool will harden over time, and it will be making an obstruction. So also known as a stool infection. So what comes is after the stool coming afterwards will seep through the sides of the obstruction and come out as a diarrhea. So if you treat for diarrhea, that's going to worsen the condition. But here, what we need is that the infection has to be removed and the bowel has to be opened well. So whenever a patient comes with the complaints of diarrhea, just ask for a period of whether they have a period of constipation before that. If then do a PRE, find out whether they have a secondary diarrhea, then manage it. So likewise, when you are evaluating a patient who complains of constipation, always ask for a normal comparison between a normal and present bowel habits. Some people may be of having a regular bowel movement like every 2 days, every second day. This will be happening from years. So that doesn't mean the patient has a constipation. If he has a normal bowel movement, which happens every 2 days, that's very comfortable. And still, if he has a 2 days, that will be the goal we are planning to achieve. We need a normal, what he used to have a satisfactory. Then always palpate the abdomen for fecal masses. In cases of infection, we will be able to palpate for fecal masses, usually in the transverse colon. And always try to do a digital rectal examination. We have to know what's the status of the stools inside them, and also know the status of the rectum. So a digital rectal examination is a must for evaluation of constipation. The drugs which most commonly cause constipation: opioids, of course, antacids, anticholinergics, ondansetron, and antidepressants. Okay, so the management is stop or reduce the constipating drugs. A refractory constipation is the only indication for discontinuing opioids. And there are conditions where opioids which are subscribed for the pain, we have to stop for the constipation. Then there is educate and communicate to the family and the patient. Then discuss the privacy issues. So privacy is an important factor in constipation, because there will be patients who will become who doesn't want to use the toilet, which will lead to a constipation due to their privacy issues, or where they won't be very comfortable in the current environment where you use the toilet, or then the regularity of the daily rhythm, seating positions in the toilet, a lack of hydration. So we will have to, of course, go into these and explore about these conditions. Ask about the nutritional effects. Are they taking enough nutrition? Like fiber-rich food, which are needed for a good habit, bowel habit. Are they taking enough water? Then is the patient can have a private, so, can we assure adequate privacy for a patient to pass stools in the toilet? Is the patient able to sit properly in the toilet? Even if the patient, the sick can walk to a toilet and use it like he used to. Those are the things which could be preventing him or her from using the toilet and having it could lead to a constipation. And always elicit and address the fears that there could be bleeding per rectum seen in cancer patients. They could be having a bleeding rectum, which they lead to. There could be withholding fluids or food which due to accept being dependent on others due to defecation. That's another common thing we are seeing in paraplegic patients or bedbound patients. They will be very anxious that they have to depend on someone else to get a toilet and pass on these tools. So they will try to hold on to the maximum to avoid such an event. This will lead to a constipation and go to other effects. So you'll sit there and respond to dignity concerns. Ensure her diet, high fiber, hydration, special diet if it's not dim feeding. Whole cereal meat, so I eat oats, rice, pulses, nuts, vegetables, fresh and dried fruits, juices. Rather than dried juices, I would suggest to patients to take fruits as a whole to ensure adequate fiber content. Then there is physiotherapy and occupational therapies. The movement has an important role in constipation because the patient who becomes bedbound will be having less movement, so he is bedbound. So that does affect the bowel motility and will lead to constipation. Then the position support during defecation. So the knee above hip joint position will be helpful for them to pass the stools. Like if we could simply help them using footstool for that. Then access to adequate commode chairs or railings to support walker. That could help them to use the toilet without less dependent on others, and we could assure dignity to them. And the commonly seen conditions where constipation plus bowel obstruction, where we have to manage the bowel obstruction. There could be a spinal cord compression, which we have to manage that. Electrolyte corrections. So hyperkalemia, even hypokalemia, hyper and hypercalcemia, those could cause constipation, and we have to correct that, which are correctable causes of constipation. Then there could be hypothyroidism, or even depression can lead to constipation. So a little thing about the paraplegic or paraparetic or long-term bedbound patients. So what we suggest for a regular bowel training is that we usually prefer a softener like a lactose or liquid paraffin syrup, which could be administered 12 hours prior to them. And they have to plan a bowel movement around 20 hours every day at the same time, which has to be made a habit. So they will be advised to use the commode, whether they pass a stool or not, for 20 to 30 minutes every day at the same time. And we also give them about around 1 glass of warm fluid about 20 minutes before this. And this had to be made a habit. So at least 2 weeks, they have to continue like this. Sometimes abdominal massage along the chronic lines can be help to stimulate the movement. Even if it's not working, we can go to next step is a digital stimulation, where we could introduce a tip of finger. The patient could himself or herself can introduce a tip of finger into the anus, do a circular movement that could be able that could stimulate it. If not a circular movement, we could also use a figure of 8 movement. Even if it's not working, we could go for a digital rectal evacuation, where the patient could remove the stool content using the fingers. So rectal intervention has to be done every 1 to 3 days at least. So a little more detail that when we do find out how to manage based on the rectal examination findings. So once you do a rectal evacuation, so examination, and you find out that if it's filled with stools, soft stools, we could go for an oral or laxative. Oral laxatives would be better option, or even a suppository, with or without a softener. And the supportive systems that we have already discussed about the drugs, the privacy issues, they has to be added. But once you do a rectal and you find the rectum as empty and collapsed, we have to realize the stimulant laxative, not the softeners, with oral and suppository. Oral or suppository laxatives has to be given without the softness and supportive. Usually in long-term constipation, the rectum, we could see that there should be hard stools where we need an enema, or if it's not possible, we could do a digital rectal evacuation. And similar laxatives and softeners could be given with them, along with education and supportive care. If the rectum is dilated and empty, high up enema has to be given, because that's usually seen where the stool will be impacted at a higher level, where we have to introduce enema with support of something like a feeding tube, where the enema is put at the level of constipation, where the stool is impacted and the bowel movements happen. There are also stimulant suppositories and all laxatives, and education and support has to be given. So that's it. Thank you for today, and we will continue the session, rest of the session on the next week. Now we can have some questions. If you have any doubts, we could go for questions.
Thank you, sir, for the presentation. If anybody have any doubts, please ask. Anybody?
You want to raise the hand? You can either speak out or send a chat. Put a question in the chat.
Ma'am Lago, do you have any questions? So we have only a few minutes. Unfortunately, we don't have a patient story today. So please put on your video. Others, please put on your video. Shruti, Nirosha, are you there? We want to see you all. Nilmi? Okay. So we had a session on gastrointestinal symptoms on nausea, vomiting, and constipation today. So I hope all of you have understand well. Any questions? If you don't have any questions, I just ask you. So if a patient, if a person comes to you with nausea, vomiting, or constipation, what are the things as nurses? What are the things we can do for that patient? We all nurses. Usually the patients directly comes to you. You are the person to see first that patient. So what are the things you could do for that patient? Who will start?
First of all, we can assess the reasons for the constipation, nausea, vomiting. Accordingly, we can adjust our management plan, whether it's a pharmacological or non-pharmacological or otherwise home remedies.
Okay, very good, Nirosha. We can assess the nausea. What are the causes of? We have to identify the cause. Okay, the assessment is very, very important. You have to do the better assessment. If you do the better assessment, you have to plan accordingly. So, okay. So our aim is to reduce their symptoms so that we can able to improve the quality of life of the patient and their family. So better assessment is mandatory for these patients. Any other things? Any other points? So after assessment, usually, so one of the doctor can see that patient, right? So after that, so we are not an authorized person for prescribing drugs. So what is our role? So we have to carry out the doctor's order, right? So after carrying out the doctor's order, what is our role? Rohani, can you answer this question? So after you carry out the doctor's order, sometimes the doctors will prescribe if for a nausea vomiting patients, you will, okay, one answer, Pratibha said maintain fluid intake and output chart. Okay, so before that, any other things we need to do? For example, if a person comes to you with a nausea vomiting, maybe drug related post chemotherapy nausea vomiting, the doctor prescribe some medications. So you have already the carry out the medications, you have given the injections. So after that, what is your role? Samir? Sunny? Okay, again,
Yes,
Pratibha, yeah, Sunny?
can you repeat the question, ma'am?
Yeah, so we are the person to carry out the doctor's order, right? So if we carry out the medications, the doctor's order, what is our role? That is,
So, if patient is nauseatic due to, as you mentioned, the case scenario post chemotherapy nauseatic patient, isn't it?
yes.
Okay. So, before giving the medication, we can explain the patient about the medication, for what purpose medication, how the medication will reduce the symptoms
Okay.
by explanation, and preparing the patient for psychologically giving support to receive the medication, because as many a time in my clinical experiences I have seen patients are fed up of taking the medication, whatever the reason is, but after receiving so much of drugs, patient is not ready to take a single PCM also. So with the psychological support, we can administer the drug, whatever the drugs are prescribed.
Okay. Any other points you want to add? Any other persons to add any more points?
Once we have carry out the doctor's orders, we can reassess and evaluate the progress, whether it is achieved or not, whether the adverse reactions are there or otherwise we can maintain the thing, and we have to document the progress and what are the actions we have taken.
Yeah, it's very good. As Nirosha said, we have to reassess the patient so that the symptom is controlled, or the patients can maybe if is there any adverse effects. We have to find out. So if the patient is that distress is not controlled, you have to reassess the patient, and then you have to inform the physician. No, so then based on their instructions, you can carry out other that further interventions. That is the nurse's responsibility. We have to reassess the patient, and you have to check whether the patient is having any side effects, any side effects on that particular injections. That is very, very important. As one of you said, Pratibha said, good ventilation. So we always provide, you have to provide a good ventilation, and along with that, you have to do the proper history. Is there any psychosocial issues there? There is a chance of developing nausea, vomiting, all. So you have to try to ventilate their, give a proper time to ventilate their feelings. So avoid spicy or smelly food, and the other thing is some of the patients can develop nausea because of the cooking smell. That is also you have to assess. So if the patient is developed nausea vomiting because of that time, sometimes the foul wounds, the foul smelling ulcer can cause nausea vomiting. So that also you have to assess well. Based on your assessment, you have to plan and treat the patient. So thank you for your contributions. Dr. Arjun was covered a lot, most of the things he have covered. So I want to highlight few things. I already shared that what is our role for nausea, vomiting, and constipation. So you have to do the proper assessment. And based on the assessment, you have to plan and treat the patients. Our aim is to improve the quality of life of the patients through symptom control. You have to do the proper symptom control, then only we can able to improve the quality of life of the patient and their family. So coming to the constipation part, as sir was mentioned earlier, spurious diarrhea is one of the that major problems, even if the patient is bed-bound patients, and few that palliative care patients can develop spurious diarrhea because of chronic constipations. So if a patient comes to you with the complaints of diarrhea, you could ask what are the bowel history. You have to ask them when is that the last bowel opening, and whether that bowel opening was satisfied or not. So you have to ask for that. So, and for a bed-bound patients, usually the caregivers come and said, told you because said that. So last few days there were constipation, but yesterday onwards he or she developed diarrhea. So if that happen, you have to take a good history of constipation. And if the patient, then you can do one thing, more than 3 days constipation, you can do a PRE and find out whether the usually if the fecal matters are obstructed in the lower bowel, so there is a balloony rectum. So when you do the PRE, you can able to touch the rectal mucosa. But if the patient is having spurious diarrhea, like upper bowel of that constipation, that fecal matter is obstructed in the lower bowel, can cause the balloon. You can feel balloony rectum. You cannot feel the rectal mucosa in your hand. So that time, what you can do is you can the management of spurious diarrhea is you can do the hypoenema. So sir was mentioned earlier during the presentation how you can do the hypoenema. You can introduce a suction catheter through the anus and introduce as much as possible, and you, from the tip of the lower part, you can through that you can give 2 sodium phosphate enema at a time, so that sodium phosphate enema reach the tip of the constipated area, the upper lower bowel obstructed area. From that rectal mucosa will be stimulated. So that is what that is why we give a high phosphate enema for spurious diarrhea patients. So that is the management of spurious diarrhea. So anybody have any more clarification, anything to ask us? Then otherwise we can wind up the session today. Anybody? Can we wind up the session? So we can wind up the session. So thank you, sir, for the excellent presentation. Thank you for your interactions. We can see you next week. Okay, thank you.